and hopefully Wendy Pena to rounding out our committee. And I see that one of our board members has also joined us, the stalwart chair of our committee on the aging, Mary Anderson. So as I mentioned a moment ago, before the tape began running, we are going to add to our agenda a presentation by Dr. Anika Sweetland, Assistant Professor of Psychiatry and Public Health from the Columbia College of Physicians and Surgeons, discussing the Columbia's new Mental Wellness Equity Center, a new initiative funded by Congressman Espaillat. So that'll be the third item on the agenda, and we will begin with a report from Captain Suching Singh, who was the head of EMS Station 13 on West 172nd Street and Amsterdam Avenue, our local base station, which of course we are very happy to have in our community and serving our community on a daily basis, 24/7. So Captain Singh, how are things going with EMS?
So first, I want to thank everybody for inviting me to the meeting. EMS Station 13 is working extremely hard to protect our community and actually help them with the health and needs. I have some statistics for you guys. Just for the last week of May, we were assigned to 750 calls in that 1 week alone. The high priority calls for that 1 week was about 314. Our response times were 6 minutes and 17 seconds. That is actually lower than the city average. It's about 7 minutes. So we're actually doing pretty good. And that part is actually looking really good. We are staffing, even though it's getting warmer, we're getting more and more calls. Like the last couple of days has been like at least 4,000, but as the summer months coming, is gonna increase. This is unfortunate, just the way it goes every year. Sorry, give me 1 second.
Steve, can you hear me? I'm sorry, I'm dialing in and I'm just not sure if you guys can hear me.
Not only can we hear you, we can even see you.
Thank you so much.
Just looking at last month in April, our total actual calls that we have responded in the morning is 1,440 calls. In the afternoon is 1,172. So the total month, we did 2,612 calls. That's a lot. It's definitely a lot. I know you guys were asking about the hospital turnaround times.
Yeah. Just to bring people up to speed, Captain.
I'm sorry.
We've had discussions at this committee meeting over the years about the delays at the hospital emergency room in getting the crews sent back out onto the street in order to respond to calls. That in the past, it's taken more than half an hour after you show up at the emergency room to drop off a patient and then actually get released, I guess, by the hospital after you do your paperwork and go back out into the streets. And we've been looking forward. We were told by the hospital that once they did their major renovation and opened up more areas within the emergency room, it would be more efficient and the turnaround times would be reduced. So how are they doing now?
So hospital, the Allen Hospital, it's actually turnaround time is about 39 minutes and 3 seconds. And this was the last week of May. Columbia University of Medical, their turnaround time is 37 minutes and 51 seconds. It's still pretty high. From my understanding from Columbia University, they do multiple steps to check in a patient just to make sure that the right information, the correct patient and the correct treatment along the way. So if somebody comes with a heart condition, they have to put the EKG on them just to make sure it's the right rhythm and then move them up to the hospital stretcher and go from there. So
your crews have to stay while that procedure is taking place?
that is one of the issues that we're having, because when they do the EKG, they placed it on the patient while on our stretcher, and then they move over to the hospital stretcher. And again, that's from my understanding, is one of the issues that my crews complain to me about.
All right, so we have to bring that up to the people at the hospital, because the times are actually getting worse.
Yes, and it is going to get worse to begin with, because again, I was saying before, we're getting more and more calls, so we're going to bring a lot more patients and a lot more critical patients as we get more summer months.
All right, so those times you just gave me were from the last week of May.
Yeah, so May 22nd to May 28th.
And I'm talking now about the turnaround times. Those were
Yes.
they were from that week. Okay.
Yes.
Well, that's very helpful. Thank you.
No, you're very welcome. But that's pretty much it. My crews have been just trying to work as best hard as they can. As you guys already aware of, we're getting assaulted left and right. It's unfortunate, but my crew are hanging in there and actually trying to help and serve the community as best as possibly can. That's pretty much it for me.
Okay, well, I'd like you to send a message back to your crews that we appreciate all of their hard work, and especially the work, in particular, the work they did during the COVID. Well, the pandemic is still going on, but during the height of the pandemic, what they had to go through, and the volume of calls, and the risk to their own lives is certainly something that we all need to respect, and we all appreciate.
Thank you. I do appreciate it. Thank you guys for your support and helping us along the way.
All right. So let me first begin with a couple of committee members who have questions. Sally Fisher.
Yes, two things. One, how do those response times compare pre-COVID? I think I remember, and I could be misremembering, much lower response times, like in the 5-minute range. And also, if you could comment on employee turnover with EMS.
So I don't have the numbers in front of me of what happened in the height of pandemic, so I really can't quote on that. The turnover rate for EMS, we actually just got 10 brand new EMTs in the last month, so we are constantly pushing out people left and right. I wouldn't know how is the turnover rate within EMS. They don't give us that statistics. That's more mostly happen in the city council meetings, and the unions fight and find the information out through FOIL, but I wouldn't have that offhand.
Okay, and in fairness to the captain, you've now been in charge of EMS Station 13 for how long?
For like 2 months.
All right. Well, so we have to give you a little bit of leeway. Tanya. Tanya, you have a question?
Yeah, I'm here. I'm sorry. Yeah, I had to. Yes. So, Steve, please tell me if I'm talking to the right people, because I could be wrong about. We had spoken about. I brought up about people, homeless people. Well, people who are experiencing homelessness, rather, being released. People who are experiencing homelessness, and how they are sort of like, what do you call it? Not really evicted from the hospitals, but what happens to them when they're sort of wandering around and they have nowhere to go after they've been treated, or even before they've been treated?
Yeah, well, that's not that's really a question for the hospital itself.
Okay.
EMS is bringing the patients in, but
right.
What happens to them after that is
gotcha.
Is in the hands of the hospital.
Gotcha. So right. we'll wait for Julio.
Yeah, well, Julio is not joining us tonight, but
okay.
But he did send me a report.
Okay.
All right. So anyone else we have? I thought I saw other hands. Does Keith McCauley has a question? Ms. McCauley, can you go ahead? You can unmute yourself.
I now see it. Thank you very much. This is a 911 question. Is it appropriate for this committee at this point?
Well, let's try it out. Let's hear what it is.
Okay. Unfortunately, I have called 911 many times over the years in New York City and a couple of times in New Jersey, and the difference is startling, with New York City being the problem. The latest time I called 911 was there was a guy on the subway, and he got off at my stop, 181st Street on the A line, and he had dropped his paraphernalia, including needles, and he was clearly getting ready to shoot up some drugs. And we have a real issue on our station with that anyway. They found, like, I don't know, 700 needles or something when they pulled away some container. At any rate, so I called 911 and I say, there's a guy here who's about to be shooting up. And every time I'm in New York, they ask me what my phone number is, how to spell all this. And I know they have my phone number. They don't ask that in New Jersey, by the way, until after they've sent the police. Here, it's like all this rigmarole. Then she actually asked me, what drug is he taking? How the hell do I know? I'm not his drug partner. And this is a consistent thing with me. It doesn't have to be drugs. It can be anything. And it's a ridiculous questions. I once called 911 because I had been thrown, I stupidly went off my bike and I was in agony. I ended up fracturing my pelvis. This was a few years ago, and I was right by the George Washington Bridge. And when we called 911, we got Jersey because we were so close. They called for us, 911 New York City. He got so angry with the 911 operator for being so, as he put it, stupid, that he asked for her supervisor. When the supervisor gets on, they end up sending the EMT to Staten Island. Now, the George Washington Bridge is kind of well known. The GPS, they sent them to Staten Island. I spent an hour and a half there. If it had been a heart attack, I'd be dead. Fortunately, it was a fractured pelvis. And I was relatively healthy, but you know what I mean? It's like, and then the person who finally did come said they didn't even know how to get there. They had to call their friend who was off duty. So it's this constant problem I have with 911.
All right. Well, it really is not within the domain of this committee. So
Hey, Steve,
I thought maybe the captain, it would be something that, Captain, did you want to respond?
yeah, actually, I know a little about the call center for New York City. Mm-hmm. When you actually call 911, it's an NYPD officer answering the call initially, and once they realize it's a medical call, they bring EMS into the question, into the call itself.
Well, they do ask me EMS, fire, or police, and I tell them, and then I get to whomever, and then all hell breaks loose as far as being held.
Well, it's actually, again, when you call New York City, it's actually an NYPD officer first, and they don't know anything about. They are to follow a rigid questions along the way, and when EMS gets on the line, we have to follow a Cardex, exactly what questions to ask. So if you're saying that you're having a heart attack, okay, what else are you having? Chest pain? Are you having this? It's a script to actually what to say along the way. I can't testify what New Jersey does. I have no clue, but
the script is they sent them to Staten Island. I was under the George Washington Bridge. Really?
So
I've also been asked, my son had a seizure, and finally the woman says to me, what do you want me to do? What?
So again, that's kind of the problem with NYPD, because they get the address and they start pushing the information to us. And that's why sometimes they ask you to verify your number, because if for some reason we get disconnected, they need to call you back.
They have my number. It's called what is it, ID? They have my number.
Again, we're working with...
they're following the script. So,
Well, we need to change the script. I'm just saying it's far better in New Jersey where I do not live and I do not want to live. But I have had experience there where they just send the police right away. That I'm still on the line. The police are already on their way. Here, by the time I answer the questions, forget about it. It's done. Or the person's dead or the person's run away. And they have my number. That's just one tiny thing. But things like, what drugs are they taking? Why in the world, unless I sold it to them, would I know this?
All right.
I'm reporting this. My son is having a seizure, a baby, by the way. And they say to me, well, what do you want me to do? What do you want me to do? Wow.
well, that doesn't sound appropriate.
No, it doesn't.
Yeah.
And I'm having a consistent issue, but I don't have this issue in other places. I'm just saying that there's something that we can change in the 911 system in New York City.
Well, if after the meeting, if we can have a conversation, I can give you a number if you make a
Oh,
complaint about
that'd be
this.
great. Thank you.
We can do that.
That would be great. Thank you.
All right. Thank you, Captain.
You're welcome.
All right. I think that's it for the time being. Captain, thank you for joining us tonight. And would appreciate it if you would come back to us on a regular basis, maybe once every 6 months or so, and give us an update on how things are going with EMS. And we certainly want to work with you. I'll be in touch with you, I'm sure, on this question about the turnaround times at the hospital.
Absolutely. Thank you guys for letting me.
Thank you very much. All right, so is Dr. Tavares with us?
He just got off the phone with me. He's having issues logging in, has nothing to do with us, so you have to bear with him.
All right, well, should we move ahead then to Dr. Sweetland?
You can. I literally just got off the phone with him and he's trying to get in. So if you want to, you can do that and then go back to him. He's trying to get into your meeting right now as we speak.
Well, let's move ahead. Dr. Anika Sweetland, Assistant Professor of Psychiatry and Public Health, Department of Psychiatry at the Columbia College of Physicians and Surgeons. And she has two other titles. She's also with the Division of Translational Epidemiology at the New York State Psychiatric Institute and with the Department of Socio-Medical Sciences at the Columbia Mailman School of Public Health. So does that mean you get 3 different paychecks?
Unfortunately, yes.
It does. Oh,
It's a disaster.
oh, wow. Okay. Well, thank you. Thank you for joining us.
No problem.
So you have a somewhat brief presentation, I believe.
I do. Yeah. So I'm just going to show slides really quickly. I'm very happy to be here to give an update about initiative in Northern Manhattan, which is very exciting. So the Mental Wellness Equity Center is a new center that started as a partnership between Columbia Psychiatry, New York State Office of Mental Health, and New York State Psychiatric Institute. And Dr. Milton Weinberg, who is the director of the center, unfortunately is not able to be here today. So I'm going to represent. I am the training director for the center. And first, I just wanted to give a very brief background of why this center came to be, which has to do with the fact that we all know that there's a huge treatment gap about mental health services, that so many people who need mental health services don't have access to them. And the situation has only gotten worse with COVID, with more and more distress. So people who previously had mental disorders have experienced worsening. People who never had disorders with the stress related to COVID have experienced new symptoms. The wait lists are extremely long and the workforce is insufficient to address these needs. And there's also a need for brief treatments that are effective and that work. About 60% of people who begin any kind of treatment drop out after 3 to 6 sessions. So there's a need for brief treatments. And there's a number of—
I'm sorry, Doctor, I'm hearing background noise. Could people mute themselves if they're not if they're not speaking? And at this point, only Dr. Sweetland is speaking. Go ahead.
Thank you.
Yeah.
Sure. So there's a number of brief evidence-based treatments that can be very effective. And what we want to try to do is bring these to scale to address the huge mental health disparities that exist, pre-existing the COVID pandemic and now after the pandemic. So the Mental Wellness Equity Center has 4 pillars: training, services, research, and education. What I'm going to talk about right now briefly is the first year of our project is going to focus on this mental wellness training institute and building what's going to be called the mental wellness community workforce. And the cornerstone of this project is this app that we have developed called the MWell, the Mental and Financial Wellness Everywhere digital platform. This tool has multiple components. First, a brief assessment tool. So with a few questions, with 3 questions plus 9 additional questions, this tool can identify people with different kinds of mental disorders or mental health problems. So things like in the depression, anxiety category, and substance use, suicide risk, which overlaps with everything else, of course, and then severe disorder, which would require an immediate referral to a higher level of care. The apps are their decision support tools that guide lay providers, so community health workers or non-specialists, to deliver evidence-based interventions with these tools that goes step by step so that they can implement these interventions. And a financial wellness tool, which is in development, which is aims to target social determinants of health. So essentially, the first step of that process will be to map out community agencies that provide services in financial wellness and to help to connect community members with those existing services. So currently, the way the system is structured is that most people are in the community and either don't access care at all or access informal support or self-help. Some people might get access at the primary care level to specialized services or to antidepressants, for example, and a very small portion will receive specialized care. And what this initiative aims to do is to build a workforce that is situated between primary care and the community, which is its community members that are trained to deliver these brief interventions using these tools for people with mild to moderate disorders or for mild conditions, that people who are experiencing situational distress or acute distress that, they might not need or want therapy for a long period of time. Maybe brief interventions for a lot of people are very effective. And so we're trying to expand the workforce in this space using this app. These apps, this is a little bit of what they look like. So the provider would be looking at these screens, and this would help with their assessments of people. It also would help. It gives feedback about what they're seeing and where what the recommendations are. It has tools that help the provider to explain, in this case, the impact of substance use on health. This is the intervention for depression, which helps people to identify people in their lives that are either connected to their distress or could potentially be a part of supporting them in moments of distress. And so the app guides the provider through these various steps of the intervention to deliver it with high fidelity and monitoring all along the way. The financial wellness tool, as I mentioned, is currently in development, but the first step will be mapping out existing services. There's lots and lots of agencies, social service agencies, or government-funded initiatives to support things like tax preparation for people who might be eligible for tax credits and don't know about it, or identify people who might be at risk of, predatory loans, or identifying people who might need access to food pantries or understand the resources in their communities. So this tool will be designed to identify the needs of the individual and link them with community services related to financial wellness. So we hope that this initiative will improve access to care by bringing it closer to the ground, closer to the community. We hope that it'll improve quality of care too, because this workforce, very importantly, will look like the community that it's serving. And we hope to address equity with this initiative. And while the first year of the program will be funded externally, probably the first 2 years through the state and through the city, we will be working along this entire time trying to figure out mechanisms through which this community workforce can be reimbursed through Medicaid, and so that this can be a reimbursable, sustainable approach to increase access to mental health services. This initiative was announced by Governor Hochul in January. The establishment of this workforce with lay personnel trained in mental health using our platform. Congressman Espaillat has also pledged money to support this initiative, particularly in District 13. And we are just in the early planning stages of what this is going to look like. We had our first planning discussion yesterday with Asociación Comunal de Dominicanos Progresivos, a local social service agency in Washington Heights that is one of the New York Project Hope sites. Project Hope is a FEMA-funded project that'll be ending at the end of summer. And so we're talking to them about trying to bridge what their crisis counselors have been doing in this COVID crisis moment and training them to deliver some of these interventions in such a way that it'll provide a long-term support for communities. And we're also beginning discussions with some local churches in Washington Heights and exploring alternative strategies for identifying people in the community who might need services, linking them with services, and really trying to adapt everything that we do to the communities in need. So I'm happy to answer any questions.
Jay, I'll get to you in a moment. Congressman Espaillat refers to it as being the Columbia COVID-19 Northern Manhattan Community Mental Wellness Core. So is this the same thing that you are now discussing?
Yes, so we have some state funding and we have Congressman Espaillat's funding. It's all the same initiative and approach. It's the same model, but we are in the early stages of figuring out exactly who the community partners are going to be and how we're going to roll it out. But it's all the same approach. I think it's looking like the New York State initiative, Project Engage, is really going to be focused on transitioning Project Hope into something that'll be long-term in Washington Heights. And with Congressman Espaillat's funding, we're still exploring, but that's where we're possibly looking into the iglesias and talking to churches and sort of, we really are in the stage of community engagement where we have a model, but we need to know, how it will best work in these communities. And we're about to engage and find that out so that we can adapt ourselves to the communities. So it's early stages.
Okay, well, I don't know whether you were briefed prior to this meeting, but increasing mental health services in our community has been for a number of years the number one expense budget priority for this committee and for the board as a whole. So this meshes perfectly, I think, with one of our goals. We're on the same wavelength, and I think personally, I'm just a little maybe skeptical about how this app is going to really work out. Whether you can really deduce somebody's mental condition by going through an app, and whether or not some lay person is going to be able to really assist someone by using this. But well, I guess how much training will the lay person go through before being able to start assisting people?
It's a great question and certainly a very valid concern. Actually, a number of us, including myself, do most of our work in global settings in low-income countries. So I work in Latin America and Sub-Saharan Africa mostly, and we've been in that space doing these interventions by lay counselors for many years, and so it's really exciting for us to bring this approach back to New York, where these interventions were all established, their evidence base was established in the U.S., but this approach to implementing them is new. The training is the key to the success of this approach is supervision. So it's not that you train someone once and then they go off and do it. It's an intensive in-person training, look for each intervention 3 to 5 days. And then each individual will have weekly supervision and needs to see a number of cases successfully in order to get certified essentially as able to provide that intervention effectively. We hope in the future for that certification process to become formalized and recognized within New York State. That's an aspiration within a year or two, but it's weekly supervision and the learning happens in practice. In group supervision, people get to talk about their own cases and learn from other counselors and their challenges. And so it's sort of a very ongoing apprenticeship approach to implementation.
So the people who are providing this service, they're doing it on a full-time basis? This would be a job?
This will be their full-time job. Initially, in the first couple of years, we have external funding, but the goal is to make this model reimbursable under Medicaid. And so in such a way that agencies could hire their own staff to do this.
So I have to imagine that the training they are given would last more than just 3 to 5 days, right? It would go.
Correct. Yeah, the certification process is about 6 months.
Oh, okay.
Yeah.
So it's really a 6-month training period.
It is.
Okay. Okay, that makes me feel better. Okay. Jay Mazer.
I have a question in 2 parts. One is a very simple part, which I'm sure you can answer, and the other is broader, which is, I don't understand what's irrational about someone who's fully employed and can't support their family feeling stressed, or someone who's about to be evicted because they can't pay the rent feeling stressed. And my other question is, many or at least some psychiatric professionals seem to feel that the problem is the way society functions is mentally ill. And the problem is that people are dealing with a mentally ill society. I have no idea if that's factually accurate, but it's sort of in line with my questions.
So if I understand the question correctly, which it wasn't totally clear to me, but I think what you're mentioning is that in situations of financial distress, or like in this COVID situation, it's normal, right, to feel distressed when life is out of control, when life is very difficult, when it's hard to have food on the table. So the approach that we want to bring really embraces that, the financial wellness and the situational distress, the normality of distress in situations of that are complicated into the model, so that it's not less pathologized, right? It's not all, sometimes depressive symptoms and anxiety and difficulties related to situational distress is normal and expected. And so these interventions are really focused more on wellness and supporting people under very difficult life circumstances to get better with an appreciation for exactly what you described. I don't know did I address that effectively?
Well, if I understand.
I don't know.
Excuse me?
In answer to her question, I don't know.
Okay. Well, I think if I understand what Dr. Sweetland is saying, is that she's acknowledging that people who have financial problems or can't pay the rent or facing eviction, that they're not being categorized as being mentally ill or suffering from a mental disorder. But the point of this program would still be to assist them to overcome that stress. Am I correct in that interpretation?
Yeah, I think having financial distress doesn't mean you have a mental disorder, but it can increase risk for, it worsening. And so what we want to do is recognize the normality of difficult life circumstances and address all of those things at the same time. So not take the financial out of it and call it a mental disorder, but rather have a more holistic approach, recognizing, that a lot of the mental health challenges in underserved communities isn't about those. It isn't intrinsic to the individual. It's really a community challenges that we want to address at a systems level to improve well-being.
All right, Sally, you're next.
Yeah, I guess I am totally confused. From my perspective, the problem that we have in this community is lack of access to inpatient and outpatient services for those with serious mental illness, not the worried well. I'm trying to figure out how this program actually addresses our most critical need. And Steve, at least from my perspective, does nothing to address what we think our #1 problem in this community is, which is the lack of access to real, true psychiatric care for those who need it, especially those with serious mental illness. Can you correct me if I'm wrong? What am I missing here?
No, I don't think you're wrong. I think you make a certainly valid point. I certainly didn't mean to suggest earlier that this is the answer to our ongoing request.
It doesn't even come close.
Yeah. Okay.
This is financial well-being for those who do not have serious mental illness. I really don't understand why we are pouring this kind of money into something that is not addressing our most critical need in this community. That's a lot of money, and that's a little bit of payback for the worried well.
Okay, I really appreciate that question. I think it's very, very well founded, and I think what this does do in that picture, it does not address adding inpatient care or adding outpatient care. What it does do is help with that waiting list problem. So what the idea is that we have this much specialized care, and we have people that need those services, and we have people who don't need those specialized services on those wait lists. So if we can pull people off those wait lists that can be addressed with lower level mental wellness interventions, it means that those specialists can address the people that need the services most. So what we want to do is save the specialists for when the specialists are needed and identify people that can be triaged to a lower intensity intervention like this. So that's how at a systems level, that's how it's intended to address that challenge.
I guess I would redirect the money to people who actually need psychiatric care, to inpatient and outpatient services, and to training, rather than training lay people for 5 to 6 months on helping people with financial problems. I would devote the money to training people who will actually be able to care for people with serious mental illness. I find this expenditure of money a misdirection of funding, especially in a city where funding is limited.
Okay. But I think we understand your point, and certainly this is not the. I agree with you that this is not the answer to our greater needs, but it is maybe a small part of the solution by helping some subset of people. But Sally, by the way, your volume is very muddled. We can't really hear you very well. To Tanya, you're up.
Yes, I just want to say I agree with Sally. about that, everything that Sally said. I just, don't understand what it's about and why this was created. I have a lot of questions about that. But I would say, if you're going to do something like this, what bothers me about things like this is it's a Band-Aid. It treats the symptom and not the disease. And so why I say that is people are stressed out over the financial things because of other systemic issues, such as racism and anti-immigrant mentalities and xenophobia and all of those things that create conditions where people are not making the money they should make. They're not having access to the resources that they should have access to, and that they are not able to afford the housing that is there. And it is more, and I was just in land use the other day. We have a new development popping up where affordable is not even affordable. And so, those are the roots of the anxiety and of the stress and of the depression of regular folks, right? And so, I think that if you're going to do it just bothers me when these programs, because they just miss the racism part. They miss the xenophobia part. They miss all the other forms of discrimination and just skip right over that. And let's just treat what it does to you. Let's not talk about it, but let's try to treat what it does to you. It doesn't work. Treat the cause. And then you will find a lot of people will be happier and they will have what they need. And then they won't be so stressed out or depressed. So, I don't get it. And I don't understand it. I just feel like there are better uses for the money. And I feel like, what Sally said, that it's not really addressing what is our, well, we've agreed as a committee that's a priority. But also I have concerns, and I think somebody else in the Q&A also expressed that, but that was a concern too, about the people who would be working with these people. I take very seriously. I have an MSW from Columbia University, and I take very seriously who is working with people who are experiencing difficulty. And too many times, people who are less resourced get the less what we call it, experienced people, and it's to their detriment. It's the same with schools, where the low income schools get the newbies, and the better schools get the seasoned veteran teachers who know what they're doing and can and have more creative tools. And so I have a question about that as well. So my first, like, how are we, just putting anybody to work with populations like that? It's not fair to them. It really isn't. As a person who, I can say, as a Black woman, I struggle to find people who have cultural competency, people who understand what I'm going through. And also, if you don't have $1 million, millions of dollars to pay certain people, you get stuck with second-rate help. And it causes more harm. You feel like you're explaining your life to someone who's supposed to be helping you. So again, my first question is about, my first concern, which you can respond to, is about, why are we not talking about what's causing all this financial stress? And let's create a program to address that. And then also about the inexperience of the people who will be working with these populations, because I do have concern about that as well. Thank you, Steve, for letting me get all of that out, but it was important. Thank you.
Yeah, I appreciate very, very thoughtful concerns, certainly things that are important to, the addressing the roots is a bigger part of the mission of the Equity Center, is the whole research piece and the social determinants of health. All of that is focused on addressing, understanding, and learning how to, address the root cause. This piece is a different piece of the puzzle that is, on the one hand, it's a workforce that's less experienced, potentially, but in this case, the Project Hope workers that are, for example, at this agency, they're life coaches, they're certified peer specialists, and they're substance use counselors that are going to be trained. So they're people with experience in crisis counseling. They're not off the street. They're people who have been doing crisis counseling for psychological first aid for a couple of years now, and have a lot of capacity and a lot of ability to do these services. I think unfortunately, a majority of the mental health profession does not look like the communities that they're serving. And there's the community, so what this workforce is going to be people from the communities who will have the cultural competence because of their understanding of their own communities, and they need the skill set to deliver these therapies or treatments, interventions that have a very strong evidence base. They're not second-rate treatments. They're, I think the goal of the center is to address everything that you have just said. I think your concerns are absolutely shared by us, and we hope in the bigger picture to be addressing all of these things.
But that's my point, though. I'm sorry, but that shouldn't be a secondary thing. Our goal is that should be the thing that you're doing. No one needs to have you putting band-aids on something. What we need is affordable housing. What we need is pay equity. What we need is the elimination of racism. What we need is elimination of xenophobia. What we need are those things. Those things, once you treat that, then all of this other stuff will clear itself up. And so that's what I'm saying. I don't, and it is second rate. A lot of it is second rate. I'm telling you, as a person who has had less resources and had tried to access these services in the past, whatever, that it is not the same. Okay. And I can say that, and that's the truth. It's like getting a nurse, a nursing assistant instead of seeing the doctor. There's a world of difference. I don't care if that doctor if that nursing assistant looks like me. That's important, but that's still a nursing assistant. We need a doctor. The doctor is where it's key. And that's what I'm saying, is that I take that very serious. And I don't think it's, we could just plop people in and say that it's gonna be the same. It's not. I don't care what kind of work they did. That, you could do all kinds of work. Is it applicable to what the person sitting in front of you? Do they have the knowledge, the ability? And I'm not saying they don't have anything to offer, but I'm saying maybe perhaps they can be trained or funded to go and get the training that they need. Perhaps that's a better use of those people, is to actually pay for their way in college instead of putting the debt that I went into. Okay? Maybe they should be paid to go to school and get the education and get the PhD, and that would be a better use of the money than this. I'm sorry, I can't.
All right, Tanya, let's Mary, you're next.
Just a couple of questions, comments. I heard you mention Medicaid. Are you going to be taking Medicare patients as well and screening them?
Yeah, so we're not, there's no criteria for inclusion that we're thinking about right now. The reason why I mentioned Medicaid is as an example of a public mechanism that funds services for people who are typically underserved. So we want it to, Medicaid is the state mechanism through which we can, we've initially discussed trying to fund these services, but that would certainly not be limited to Medicaid by any means. Medicare is a federal program, so there's different structures that we'll need to explore, and we certainly will. We certainly will.
And the reason I'm mentioning that, because, we always have, I'm the chair of the aging committee on Community Board 12, and we always talk about the geriatric population and their lack of ability to find appropriate services, psychiatric services, because it's a special population with special needs and concerns, and they sort of get the, usual run of the mill stuff goes on without addressing, the aging issues and, the fact that they're dealing with, their decline and all that kind of stuff. So, that's a concern that my committee always has.
I'll definitely bring that back to the group because we have only been talking about Medicaid so far, but I really suspect it's just because we've been talking to the state. But certainly Medicare will be part of our solution process, trying to find ways for, expanding the workforce, the mental health workforce, so that more people can get treatment in ways that are that's sustainable. So thank you.
Steve, I just want to say that there's a question in the Q&A that you might want to address.
Well, I think Tanya basically already did. I mean, it's licensed counselors typically have years of graduate training and 1 to 2 years of supervised experience. Counselors with days of training is significantly less. How is this handled with licensing laws and other aspects of guaranteeing quality?
This is an excellent question, and this is one of our agenda items in the next year or two, is to figure out how this workforce, this community mental wellness workforce, will be supervised by those licensed providers. And the training, like I said, there's an intensive training right at the beginning. That's just an introduction. That's just the tip of the iceberg, and really, all of the learning happens in seeing actual people, seeing patients, talking about it every week with the supervisor, hearing about the experiences of other counselors. The learning doesn't stop after the training. The training is really just the introduction. So these are big questions that we're also thinking about, and thinking about how we can be as rigorous as possible in guaranteeing and ensuring quality. So one of the advantages to these apps is that it gives us a lot of data, right? Because a person using the app, going through each of the steps, first of all, it involves an assessment of each patient and each encounter, but also going through each of the steps of the intervention. And we can remotely monitor that. Are they using, say most counselors use this, these different screens for 30 seconds each, and this one person is using it for 20 minutes. Like it can flag people who are using the apps in an irregular way, which would be a signal to us that there's low fidelity to the intervention, or they're not quite following it in the way that they should be. But we also have very close monitoring of symptoms on every encounter basis. So we can identify a counselor very, very quickly, not just because they tell us, but we can identify if a patient, if a single counselor has patients that aren't getting better or aren't responding, we can intervene very, very quickly. So that piece that the apps, that's an advantage to the apps that gives us an added layer of clinical supervision and ability to ensure quality, because we can flag things right away. We can catch it in real time and be intervening. So, so there's more oversight. So these are very important questions that we are going to be exploring, and these are some of the ways that we'll be looking at them.
And we'll
together with New York State.
When these counselors make recommendations to patients, are those recommendations only made after a licensed professional has signed off on them?
So my understanding of the nuances in that space in New York State is that there's very strict rules about who can do what, who can diagnose, who can treat, who can, and this is, we're trying to gain a better appreciation of those nuances right now. The counselors will be, the apps guide the assessment process. So I can, if anyone is interested, I can explain at another time how this assessment tools were developed. But essentially, it was, we've demonstrated statistically that using these, like, so for example, the PHQ-9 Patient Health Questionnaire is a 9-item depression screening tool that many of you have probably seen in primary care. There's similar instruments for, that's for depression. There's similar ones for anxiety, a 7-item scale. There's ones for psychosis, for PTSD, for substance use, alcohol, drugs. And so what we did is we had people do all of these screening instruments, and then we checked it against a clinical diagnosis. And we found that 3 items out of all of those scales had a very, very high ability to identify someone with any mental disorder, with 94% sensitivity, which is extremely high, that we could exclude people very quickly with 3 questions that have no mental health needs. And then for those people who had some mental health need, asking an additional 9 questions could put them into these categories. So the decision making is taken, is the counselor is using structured tools that have been validated and used for decades in the US. There's nothing new that's happening, but the algorithms guide them in a way that can give us confidence that assessment is happening in a rigorous way, in a quick and efficient, rigorous way that can flag people very, it's not just the symptoms, but the severity. So people with higher severity get referred right away. And it's the people of the lower severity that could benefit from a lower level of care that we're keeping off those wait lists so that the people who need the specialist can get the specialist care.
Jay, is that another question?
Yes, it is. First of all, I think this program, whatever we think about it, is funded. And it actually doesn't matter if, compared to the basic needs of our neighborhood, this is just micturating away public funds. It's going to happen anyway. On the other hand, we all still have the same questions. And one of them that occurred to me in your presentation is, I don't understand what you specifically mean by getting well. If we're dealing with people who have high stress and anxiety for real world reasons, and we don't have real world solutions to those questions or problems, as you'd say it.
Okay, so if I understand, you're asking, what do we mean by getting well, helping someone to get well when the person's when the person is stressed for real world reasons and we don't have a real world solution. So we have someone who, for example, is stressed but reasons like, institutional racism and housing issues, and sort of without having a solution to those issues, how are we going to help people get well? And I think that it's a really, really good question. Not everyone who has housing issues and experiences adversity has a mental disorder, but those that do can often benefit from, brief interventions that are like skills-based and helping to, so a big piece of interpersonal counseling, which is one of the interventions, is, for example, helping a person to recognize how symptoms are linked to social events or social triggers, and how to, by understanding that, learn to live in their world differently in such a way that will reduce symptoms. So it's, just because we don't have the whole solution doesn't mean we can't help with the problems, I guess is how I would respond to that.
All right, well, Sally, you have another point?
I guess just a general comment, which is, I find it inappropriate that this is considered a mental health application. I think it should not be addressed as that because it's not solving our mental health needs as a community and as a society. So I think maybe misnaming it as a mental health solution, it's not a mental health solution. It's basically addressing stress for the worried well. And just like the Thrive program misdirected its funds away from people with serious mental illness needs, this seems to me exactly the same thing. It's pouring a lot of money, which, as Jay said, the money has been allocated, but I think the money's been misallocated. I don't think we should be spending money on programs like this that do nothing to address our mental health needs as a community and as a society. And I just want to say that for the record, to make sure it's clearly understood where I stand.
Okay. All right. I think we've made many of our points, and I think we're going to want to hear more, I guess, as this program develops, to see how it actually maybe affects people in our community. Hold it a second. All right. All right, Tanya, do you have something new to add?
I just wanted to respond to the Thrive program had its problems for sure, but I do want,
which
can
program?
you hear me? The Thrive program.
Oh, Thrive. Oh.
Had its problems for sure. But I do want to say that the Thrive program tried to encourage some people who had never been in therapy, because of course the lack of cultural competency to get into therapy, where they weren't especially communities of color accessing therapy. Again, I think what plagued the program, what has been a problem, which I think will be a problem with this one, is that, you know, the people that were seeing folks, again, there is a level of lack of experience or to better meet the needs of the people that they're serving, which is a problem, and then all of the other limitations. So again, I just, you know, I think we want to be fair, and for communities of color, that program did open up the door and encourage people, and people did access therapy where they had not before. But we have to also acknowledge that, you know, the limitations of that program, and it will be the same with this. And just wanted to be clear about that, because I just, you know, people's experiences are different based on how they're situated in our society. And so just need to be aware that it did help people in some ways.
All right. All right, Dr. Sweetland, I think maybe you've earned at least one of your 3 paychecks tonight. But I thank you for coming and listening to us. And I think we've given you a lot to think over. And hopefully you'll come back to us when the program is more developed and there's more to talk about. Thank you for sitting here and listening to our comments.
I appreciate it. Thanks.
Next on the agenda, I see that Dr. Tavares has joined us. Dr. Fernando Tavares is going to discuss a proposed overdose stabilization center. And he's the founder and director of an organization called MIH Experience Limited. And maybe it's also called My Hope 2020. But Dr. Tavares, you can explain that to us.
Yes, thank you for the opportunity. I am accompanied by Dr. Rodney Campos, who is the program director of MIH Experience, and as I said, DBA My Hope 2020. We have an outpatient service in the community serving Washington Heights and Inwood community, as well as many other patients from other communities, Bronx and basically and Lower Manhattan too. But the idea is that we are.
I'd say before you go further,
Right.
I think you're located near Broadway and Nagel Avenue. Am I correct in that?
We're at
Yes,
4580 Broadway,
What-
between 196 and Nagel Avenue.
Right. Yes, there's a
It's a storefront, correct?
yeah, there's
Correct.
a storefront. In fact, that used to be used by Columbia before, as many years ago was the mobile crisis unit over there,
Oh, okay.
which I was also part of back many years ago. Okay, so that's our outpatient service. I also have a psychiatric practice with probably one of the largest privately owned psychiatric practice in the community at Centro Médico Dominicano. And I'm also
And that one is on 185th Street,
exactly 185th Street. Yes,
where Wadsworth Hospital was once located.
exactly. So you know exactly what that is. Yes, Wadsworth Hospital was this building used to be. And also, I am also helped by Hawa Jallo. Hawa Jallo she's also in the as a participant, and she's going to be presenting more of the details of what we're planning to do. Is what we call an stabilization center, meaning it's a type of service in which we want to include the inpatient detox and rehab as part of the treatment for this community of patients who have an addictive illness, serious addiction crisis. We can call this like not only an addiction crisis center, but also an overdose prevention to be able to serve a community that includes a wide range of ages. We have a younger population that is unfortunately now very seriously affected by all the drugs again. I mean, I've been in this field for more than 30 years, and I have seen, I've never seen so many young women and young men using alcohol so seriously. And obviously, you know, we remember the crack crisis of the 90s, and now is alcohol. And in the elderly population, we also see in the opioids dependence that is happening more than ever. But you know, I probably don't need to say how serious this crisis is in our community. But the idea is to see if we can complete a more community-oriented type of service, knowing the community very well. And unfortunately, we don't have in this community a place that can offer inpatient detox and rehab in a stabilization manner with a good connection with the programs in the community that serve the Spanish-speaking population. Most of the places that we send the patients to currently are not culturally oriented, are marginally doing that, but not at the level that we require. And we have noticed a limitation in the patient when they come out. For example, we were just commenting about a patient who is 70 years old. He does not stop drinking, but every time he goes to an inpatient unit, he does not connect with that type of service in that community and in that inpatient unit. So he comes out very quickly. So it's a failure in that sense. So, I mean, there are many reasons why. But I want Hawa Jallo, who is also a participant, to see if she can present a more detailed plan for what we're planning to do. Is Hawa available to?
Thank you, Dr. Tava.
Yeah, she's here. Yeah, go ahead.
Now, I was just saying, thank you, Dr. Tavares, and thank you everyone for having us and taking the time to listen to all those presentations. I have a PowerPoint I would like to share. If I have access to share, I'll just share it.
I think you can just go ahead and do it.
Yep, I did.
Oh, very good.
That's good. So as Dr. Tavares was presenting, he is already a member of this community and already providing vital services to the community. What I have here to share with you is the feasibility study that we did to see if there is a need for this type of service in the neighborhood.
Okay, could you just tell me, do you also, could you go back a moment? Do you also have a facility at 659 West 179th Street?
That's the address of the facility.
That's exactly what we're trying to do.
Mhm.
So
This is
we're presenting that location as the place where we're planning to locate the inpatient or the stabilization center. It's going to be a connection. The MIH in 196th Street is an outpatient service only.
Right.
So you're a block away from the corner project.
No. This is all the way on. This would be
This is on near Broadway.
Okay.
Between Broadway and Wadsworth, to be more
It's
specific.
90 feet from Broadway. It's like it's near between Wadsworth and Broadway, in the corner of across from the GWB terminal.
right. Okay,
So,
on the north side of the street there.
Right.
right.
Yeah, okay, I'm sorry. Good. Ms. Jalo, right?
Mhm. Yes.
Sorry I interrupted you. Could,
No,
I'm sorry, go ahead.
no worries. You can interrupt at any time. I prefer that anyway.
No,
So we go back and forth.
Okay, no, go ahead.
So this is at 659 West 179th Street. Can you hear me?
Okay,
You can hear me?
yes, I'm sorry, go ahead.
Okay. So in the extreme northern Manhattan in Washington Heights by Little DR neighborhood, that's where this building is located.
Right.
So it's also like 5 blocks from Alexandria Hamilton Bridge,
Right.
to the Bronx and George Washington Bridge, just
Right.
to give a little description. The building was built back in 1900. It's a 3-story building right now with 6,000 square footage building and 33.33 feet depth and 45 feet. The property classification has an office in the past. So it's around the Washington Heights demographic. Washington Heights demographic gives us 21.7 Caucasian, 7.5 Black, and 64.2% Hispanic, and 3.5% is Asian. So that's what we found in the research. So it is predominantly Hispanic population in that area. So mostly Dominican neighborhood, which is 9% unemployment, rank 39th out of 69 police neighborhood in the 5 boroughs. And that's basically talking about crime. So in 2020, there was 7 murders, 16 rapes, 205 robberies, 213 felony assaults, 226 burglary, 444 grand larceny. So, but a 42% decrease in crime since 1998, which is great. And this location is right next to the A train, the 1 train, and the C train. You see that in the next slide. So it was formerly occupied by.
Yeah, let me interrupt you again for a moment.
No problem.
This location, it's a little difficult, I think, to really do statistics on crime unless you're including both the 33rd and 34th precincts, because this location is right on the border between the 2 precincts. I think, if I'm correct, 179th Street is the boundary between the 3, 4, to the north and the 3-3 to the south. So, if I were you, I would probably look at statistics for both of those precincts. You may have already done that. I'm not sure, but you might want to take into account both precincts, which cover all of Washington Heights as well as Inwood.
Okay, interesting.
I thought it was lower, like the 33 was lower. I mean,
no, it goes up to the bridge, and the dividing line, it's either 178 or 179th Street.
So I looked at the 34th precinct.
Right.
Oh, okay. So that's a very interesting.
Okay.
Okay, so definitely we'll look at it again.
Yeah, go ahead.
Okay, but thanks for that information. It's very interesting. It's part of New York State 13th Congressional District and the 31 State Senate District with Robert Jackson. And the colleges that they have around there is Receiver and, oh my God, I can barely see. Berwick College.
And Columbia.
And Columbia in the neighborhood too, right?
Well, the Columbia University, medical school and the nursing school and the School of Public Health. Columbia has a number of schools up in the Heights as well.
Right.
It's the amazing thing about this area is centrally located.
Right.
Like I said earlier, we have the 1 train, the A train, and the C train.
Right.
All around right there in the neighborhood. So what that makes it is more accessible to everyone that needs to get to that facility.
Yes.
So this is the building, just to give you guys an idea what it looks like right now. But what Dr. Tavares is looking to do is really add to it to give more space and trying to occupy about 42 beds. Correct me, Dr. Tavares, if I didn't get the number right, but it's about 42 beds. And what we're looking to do really is to move from traditional drug programs, putting so many people in one room. So what we're looking to do is individualized bedrooms. So this way people can be in their own room by themselves, because we're finding out a lot of times too, when people go to inpatient treatment, they are unable to stay because you have too many personalities in the same room. And that creates a lot of friction and distraction for people. So we're looking to do something different to make it individualized room for each client that comes into that treatment facility.
Is the building occupied right now? Are you using?
No, it's not.
Oh, it's empty.
It's not.
Okay.
Yeah.
It's empty and it'll be renovated to fit the need of the program.
Okay.
That takes
I'm sorry. Do you own the building?
Yes.
Okay. Oh, very good. Okay.
So we took a look at the overdose data that was shown back in 2020. And as we known with COVID, that became way higher. It was not much attention that was given to the overdose as it was given to COVID, but in reality, there were more people dying from drug overdose in comparison to COVID, especially with the new drugs introduced, which is fentanyl. So a lot of people have been dying because they're mixing the fentanyl, the heroin, and the benzos together, which makes it very bad and creating a lot of overdose. So based on the data that was released by the Department of Health for 2020, Washington Heights ranks is around 50% percentile of the neighborhoods in New York City for overdose death. So we're talking about 27.3 per 100,000 residents. So that was the research that was shown for the 2020 research. And when you look at that neighborhood, you really don't have this kind of programs around there. You do have outpatient programs, which is the 822 outpatient clinic. So we have the Alliance for Positive Change that is over there. And then you have August Community at 507 West 145th Street. And then Bailey House, Creates, which is at 75 Lenox, and Vita, and then Upper Manhattan Mental Health Center and Palladia, but these are all outpatient programs. And then there's also 822 OTP, which is also known as the Methadone program. One is with Beth Israel. Then you have Metropolitan Hospital and Star Methadone Treatment Program.
But I'd say most of these are not in Washington Heights.
But these are the surrounding, what is closer to Washington Heights. So
Yeah.
they're really not in Washington Heights, but they're closer to Washington Heights.
Yeah, but yeah.
So that's what makes what we're trying to do also more valuable, because when you look at Washington Heights, you really don't have much right there, and
Right.
there's a high need. So there's also a 816 and 818 program closer to there, which is at 151 West 136th Street. And that's the only program that have it there. And then you have the residential program, which is just 2 of them. And again, in the near neighborhood, which is 3.4 miles. So bringing it in there is a need. When we look at the feasibility study, is that you have a place that have about up to 50% of drug overdose that do not have a stabilization center right there in the middle of that neighborhood that needed it the most. So what we wanted to present here today is that Dr. Tavares already is a member of this community. As I listened to the previous presenter and listened to the questions from the board, it is very impressive to hear a board this dedicated and being an advocate and a voice of what the community needs. You know, Jay asked the question earlier, has to, you know, is somebody not getting their money to pay their rents, leading them to mental health? You know, in the addiction field, we ask, is the chicken or the egg? What comes first? We don't know. You know, what we learned during COVID is that we don't know how many people do have mental health, because for some people, they have been able to manage. There's also the theory around the nature versus nurture. So some people were able to survive through the nurture, but then when the crisis hits, it exacerbates that mental health that was being taken care of the nurture. So Dr. Tavares speak about earlier too, being culturally competent. I always say being culturally sensitive. In a neighborhood with high number of the Hispanic population, him being already a provider in the neighborhood and own this building, instead of sitting there more like an abandoned building in the neighborhood, he is willing to get the building together to meet the needs of the community. So he already have programs that he's running and focus a lot more in that cultural sensitivity. With this program, it will not be just addressing substance abuse, but it's addressing the individual as a whole, using a holistic approach, making sure that the person's mental health is addressed. Because there are a lot of times where substance abuse and mental health goes hand in hand. If the person is homeless, if they come through this program, the program will work with them to refer them to a residential facility or housing facility. There are supportive housing agencies that do take individuals coming from a substance abuse treatment. If the person have a medical issue, that will all be addressed. Dr. Tavares himself, he's a psychiatrist, so the mental health of every individual will be priority to address. There's a piece too where addiction is being looked at as a disease, so it should be treated as such. We will be able to use medication to treat individuals with their addiction, their mental health, and medical issues. The goal is to hire competent staff, making sure that a lot of the staff that are being hired are licensed staff that are trained and equipped to deal with trauma. Because in my years of being in the field, which is over 25 years, what I've learned is that a lot of people that turn to drugs and alcohol, they're basically medicating their trauma, or they may have undiagnosed mental health symptoms that they're medicating. You know, so addressing the underlying trauma that people struggle with and addressing their psychosocial stressors will be a key to this program's success, you know, making a difference for the community. This is not a funded program by a government. This is Dr. Tavares would be responsible to get everything together financially. However, once we start taking patient, the services that are provided to the patient will be billed to their insurance. And that will be taking all insurance, including all managed Medicaid, Medicare, commercial insurance, whatever the need is. So we will be credentialing with as many insurance as we can. So this way access to care will be provided to all of those that need it. For individuals that don't have insurance, we will work with them to see if they're Medicare eligible to make sure that they get insurance to get the care that they do need. So we're here today presenting it to the board to let you know that we wanted to be in partnership with the board, and Dr. Tavares would like to continue his work in the community in adding this service that is needed to the community, which would be an inpatient detox and rehab to stabilize people going through withdrawals and get them to their next level of care. We will use, once we get the blessing from the board, we will go in front of Oasis and do a letter of intent to start the process. And Dr. Tavares will be working with architects that he already have some drawings to start the renovation of the building and making sure that it's accommodating what the program need. The modality of treatment we are giving will provide the location OTP less than a mile away. Those people that are in that neighborhood don't have to go anywhere else. So we'll be sending in the application to Oasis once we get the blessings from the board. We will be doing marketing within the neighborhood and within the 5 boroughs, and working with shelter system, hospital systems, the community, churches, business people in the community, because for many, many years, addiction has been treated as a silo, including mental health. But what we're learning more and more, the more we work together, the better we're able to help the community as a whole. Because the individual struggling with addiction, it's not just the individual with the disease, but their family is affected, the community is affected, politicians are affected. Everyone around that person is affected. It's actually a major crisis. It's a health crisis. And we can turn our face the other way around because it creates unsafe environment. The individual themselves are not dangerous, but the drugs that they use make them behave a way that becomes threatening to society. So for everyone have the right, it's a human right to have treatment for whatever disease that you're struggling with. Just like a person have the right to have treatment because they were diagnosed for cancer, an individual with mental health, substance abuse, and any other medical issues so far have the right to also be treated. I'm gonna stop here and welcome any questions or suggestions that anyone may have, or if Dr. Tavares would like to add anything to everything that I just said. But this is where I'm stopping for now. Thank you for letting me present.
Well, thank you for your presentation. And I would appreciate it if you would forward the PowerPoint to me so I can refer to it as I do the minutes of the meeting.
Sure.
And Dr. Tavares, did you want to add anything at this point?
Well, basically, like Howard was saying, that it's like, we're trying to see if we can collect as many services as we can that can help this community, because obviously, we understand. I mean, I've been an attending physician at Columbia Presbyterian for more than 20 years, and I understand that Columbia is providing numerous services, but you see, there is no real program coming out of that big institution that can provide these type of services in this community. Obviously, we have something that this community needs.
I'm sorry, I have to move to my desktop. It looks like my laptop is dying, so I'll be switching to the desktop. My apology.
All right, let me just ask a couple of quick questions before I turn it over to my committee members. Could you tell me again how many beds you hope to have? How many people you hope to treat in the facility?
So we're looking for 42 beds that this building will hold. I'm sorry, so let me hang up from here.
Oh, there are now two of you.
I'm coming off the laptop.
And let me tell you, one of you is really sufficient.
Yeah.
I'm sorry?
Okay.
Yeah,
So,
one of you has already done a very good job. So,
Thank you. I'll take that as a compliment. So as I was saying, it would be 42 beds
okay. And
that we're looking.
and there were a couple of abbreviations or initials on that last slide. So MMTP is a methadone maintenance. Is that correct?
Right, methadone maintenance treatment program, which is now called has opiate treatment program, OTP.
yes.
So you
MMTP was the old name.
okay? Well, I'll go with the old name too. But
Okay.
so that would also be part of this facility, correct? You would also provide.
Correct.
So
Correct.
isn't that's really an outpatient program, is it not? You would.
So it does get administered at an inpatient level and an outpatient. So what's happening right now with the overdose, it makes sense that we move away from detox to stabilization. And with that, we're able to induct people at an inpatient. So this way we transition them to the outpatient. Because what we're finding out that when you stabilize people, you induct them with medications like methadone, the likelihood for overdose is very, very low. But when you detox them, they come out, they clean, they go back to using, it's very easy for them to go on overdose. So now the field is learning that the stabilization is safer than the detoxing.
And I also wanted to mention that, the latest development is that we are, like I was saying, that the reality is that the more comprehensive the substance abuse programs are, the better they can serve the community. These type of services that used to have like, okay, outpatient here, inpatient there, and then OTP here, sort of like disconnect the patient very easily. So if we can maintain as many services in the same umbrella, is much better.
I'm sorry, and what does OTP stand for?
I mean, opiate treatment program.
Oh, opiate treatment program.
Right.
Oh, I'm sorry, Davro already said that. Opiate treatment program. So, so you would stabilize the patients and then put them on a methadone maintenance program. So in order to hopefully prevent them from falling back to their to substance abuse once they leave the facility. You would hope to keep them on an ongoing basis through keep them out of an addictive mode by having them on methadone maintenance. Is that correct?
Correct. And there are other medications too, other than just methadone maintenance.
Yes,
but the goal is to keep them on medication for those that choose to be on medications.
Right.
So this way it helps keep them stabilized.
Right.
And also put them at a very low risk for overdose.
Okay, but the methadone is the instrument by which you would have them stabilized.
Methadone is one of them.
It's one of them. Okay. All right. Very good. Okay. Tanya.
Yes, thank you, Steve. First of all, I wanted to say, yeah, we definitely need, obviously, more facilities to inpatient to treat people dealing with substance use disorders, for sure. And that a lot of times is co-occurring with mental health issues as well. So definitely a need there, and definitely appreciate you Dr. Ferris coming up with trying to bring these more resources to the community. I have a couple of questions about you gave us some statistics about the demographics of the community, right? But I wanted to find out, what are your statistics on the substance use disorder in this community with those same populations? Because the demographics and tell us who's here and the number of people who's here, but it's not telling us really who would access those services, who is in need of those services, right? So I was curious about whether you have that data or you will be getting that data. I definitely recommend you do in your continued discussions, not only with this community board, but with others, so that you can show the need, not just in demographics, because people can live here. That doesn't mean that they're having, they're struggling with these issues, so that you can show that the need in a greater way. So I was just curious whether you had those statistics or have any idea of that. The other thing I wanted to say, in terms of your marketing, I would go back and think about it just a little bit, because the reason why I say is because we do know, this community is definitely predominantly, Hispanic. But as your statistics also show, there are other populations of folks who are here, who need services, who might access. Again, we don't know what the data shows in terms of who's needing those services. But I think to open it with an emphasis on just one part of the population is probably something to think about. Because if you want this to be for the community, then it has to be for the community, meaning everybody who is here. So I think, describing things as the little DR, which is something that didn't come from, us. It was above us. And you understand what I'm saying? It was above me now.
I understand.
So that was not a decision. So I think that, using that language, I just would say with marketing, if you start from if you start from a point of exclusion, it's going to be problematic, right?
Well,
so yes. So just, I'll leave it there. Let's take that. Okay.
So you know what, Ms. Tanya, thank you so much for your highlights.
Sure.
On page 5, we talked about the data. The Washington Heights rank was around 50% on the drug overdose in the neighborhood. And that was data that we got from the Department of Health. In terms of the marketing and in terms of the population that we're targeting, we're not targeting any specific population. If that came across that way in the presentation, that's not the intent. The population that the marketing is gonna be targeting is any individual that do have substance use disorder, has their primary diagnosis. And that can come with anything else. As long as they have substance use disorder has a primary diagnosis, they can have mental health, they can have homelessness, they can have a socioeconomic background, their race does not matter, their income does not matter, their religion does not matter, as long as the only criteria is that they have a substance use disorder has a primary diagnosis.
Yeah. I think your stats do need to be more specific, though. Just like I get that the amount of overdoses, but it doesn't tell us who is more about that. Who's overdosing? That's what I'm saying. Getting more specific so we know who's needing these services in the community. And the marketing does it stuck out to me immediately.
Got it.
And that was the first thing I saw. I'm just telling you. Okay.
I appreciate that. Thank you.
Okay. All right. Jay Mazer.
You can tell when a social worker is in the house.
Right. So we currently, the outpatient service that we are offering currently has, the same model, that the population, and you can tell by our staff is like we have all the diversity of the staff, and also I would say the same more or less that we are expecting culturally and the population of patients is. So we probably maintain is not necessarily only little DR. We do have many patients of all races and religions and culture. So the same in terms of the population of patients as well as the staff. So we have that right now. So Dr. Campos is.
I am the director. Oh, first of all, good evening. Thank you for allowing me to be here. I can speak to My Hope 2020. And in essence, it is correct. The majority of our patients are Latinos of various countries. We are able to service them in an environment that's culturally comforting to them. Most of the staff speaks 2 languages. We give services in Spanish and in English. Just to break it down a little bit for you, I would say that 80% of the population in our clinic is currently Latino. The next biggest group would be African Americans. And then there are, I'm gonna say African Americans are about 15%. So that's, and then 5% are Caucasians, to be honest.
And Asian too.
And yeah. Let's take away from the Caucasians, there may be 2% Asians. The reality is everybody feels at home. Everybody feels that they are treated with dignity, and we never shame anybody for having an issue with substances. We don't call them addicts. We call them, you have a substance use issue. And we make it very clear that it is achievable to contain, to gain control over this use. The reality is, a lot of the people we service don't find that when we send them to Columbia, send them to Allen, send them to St. John's by the Sea, or other institutions, that they get the same, comfort, because people are speaking to them in their language. I appreciate your statement, because I do believe that moving forward, those statistics will be in my hands, especially moving into something larger. But the reality is, this is a predominantly Latino neighborhood with a very poor population, a very undereducated population. And let's face it, unemployment has not decreased because of the pandemic. Unemployment was higher. In many ways, the people who got that stimulus check used it to party, and then found themselves a month later with an addiction issue or a substance use issue, whatever term you feel most comfortable with. And we didn't label them anything. We just said, you need help, we are here. And we want to expand that concept of treatment, that concept of treating humans as humans. And although we're throwing these demographics around, we really are not looking to label anybody. So I get your point. I appreciate it. I think it was well highlighted. And as I said, those statistics will be in my hands the next time. However, the reality is, it's a predominantly bilingual clinic, and it serves the population really well.
And obviously serves a real need. Dr. Campos, so I have your information correct. You are the director of the My Hope 2020 program?
Correct. I am the program director.
You're the program director, and that is the outpatient program. Is that correct?
Correct.
Okay. That's the one at 4580 Broadway.
Correct.
All right. Very good. It's good to meet you.
Pleasure meeting you, sir.
Jay, did you already ask your question?
No, I haven't asked a question.
All right, go ahead.
You mentioned about people paying for this program with insurance, and people with insurance are generally housed, and housed people are much more likely to both have Narcan and to shoot up with other people present. And actually, most people who take more drugs than they intended to and lose consciousness seem to get better either on their own or through the assistance of the people they're using drugs with. So I don't quite understand. Are you looking for the same population that the Safe Injection Center has? Or are you looking for a different group of people in the Heights? And
I'm sorry to interrupt.
That's a very interesting question, yeah.
We encourage every opiate user to not use alone because people can overdose. However, I have two glaring examples of individuals. One died in a McDonald's bathroom. The other, a young lady from Ohio, died after successfully getting off all opiates, gave birth to a beautiful baby girl, then went home, experienced something, and they found her dead in bed with her infant. That traumatized my staff. People were sitting around crying. And we are trying to, and I'm sorry, a lot of people who go get into the hospital, get Medicaid, while they're there, leave with the Medicaid and are homeless. We work with multiple people who are in the shelters. You may consider them being housed, but they don't have a home, is the way I see it. And the reality is those people don't always have a place to land at. If they don't get back to the shelter within the regulation or times, they're on the street. So I don't consider them, maybe they're underhoused, but I don't consider them having a residence.
No, not if they're in a shelter. But I think the question is.
Actually, I had another question, if it's okay.
Yeah, but the other question was, the other part of the question was also that we are planning to have the population.
If we're looking for a different population other than the location that she was referring to, and I guess my answer would be anyone who needs help, we're offering it.
We understand that those people, I don't know if you're referring to the patients who go to those corner project or something like that. Is that what you're referring to?
Yeah.
Right. Okay. So, there are many of those individuals, those patients who go there. I say patients because they are not patients yet necessarily, but they're ill. They're sick people. They're people who have an illness. When they're ready to come to us, we are ready for that. But honestly, we're not necessarily trying to, but definitely having a program available in the community definitely will be helpful to address those issues. But
Well, I think it would be good if you developed a relationship with the corner project.
We tried early on.
We made an attempt, but unfortunately, that's why this service could be much better capacity. We will be much better capacity to serve, because there are many of those patients who are not ready yet. So then obviously
Right.
But we are there, and whenever they're ready, that we are there. And I think we can approach them, which we've done before. But honestly, most of them will belong to an inpatient service on many occasions. So that's why we're trying to see if we can have this service.
Well, I tell you, Wendy, I cut someone out off before, but the fact is, the corner project is about 5 blocks away from your building, and it would only be logical, I think, if there was some kind of ongoing relationship or partnership between the two of you. And when the corner project made a presentation to us a few months back, they told us that they had people on site from rehab places who were there ready in case somebody, decided that they were ready for rehab. That they could turn them right over and they could be taken to a rehab place. So, and that to me was actually one of the most positive things I heard in that presentation, that there was an immediate opportunity for somebody to realize that they shouldn't just be shooting up, but they should treatment. And hopefully, if you're right there, if you have somebody right there, they can turn to you and you utilize your service.
Well, I can tell you one thing. I am not, other than a person who wants the community to do better. I mean, I've been here in this community for so many years, and I'm planning to be here for as long as I can hold it. But honestly, I definitely wanted to see if I can be a contributor to reduce the unfortunate situation that is going on with this corner project. This is my view.
All right. Well, maybe we can talk some more about it.
Actually, can I continue now, Steve?
Oh, did I go ahead?
Yeah, my questions were more about the use of the methadone treatment. First of all, what do you do to prevent methadone overdoses? Since methadone is an addicting drug as well as heroin and other opiates. And how does that work? And how long, as a rule, do people stay in your methadone treatment program? Is that a lifetime program or what?
So I'll take that. The treatment is patient-centered. So it is a patient choice whether they want to get on methadone or they don't want methadone. There are other options of different medications, such as Suboxone, Vivitrol.
Yeah, but that wasn't my question, really.
So the methadone, it depends on the individual patient, how long they want to stay on the methadone. They don't have to stay on it.
But my question was how long they do stay, not how long they wish to stay.
Some people can stay a lifetime and some people don't. So again, it all depends on the individual patient, is this the type of treatment they want to continue? I have seen people that got onto methadone, and then after they got better, they're not experiencing cravings anymore, and they came off. They detox themselves and come off the methadone, and they were good.
And the other part of my question is, what do you do to avoid methadone overdoses?
Okay. Well, the methadone overdose is basically, I mean, we have we give every patient a Narcan, which is a preventer of the overdose of the death. Basically, I mean, the overdose can happen, but at least the patient, if they're able to themselves or somebody else can administer this intranasal treatment to prevent, at least for some time, the overdose. That will be an emergency treatment. But the prevention of overdose is basically done in a clinical manner in such a way that the patient themselves are able to know the risk of this and preventing, especially when they finish a treatment for an inpatient, and they go into what is called the reduction of the level of tolerance, that's exactly what the riskier moments are. So those we try to see if we can maintain a very good close contact with the patient at that time, or at these most risky moments, and also we can pinpoint the patients who are by keeping the patients, under control and seeing them more frequently clinically, we can really address those issues and those patients who are at risk. So it's practically impossible to prevent everyone. And obviously, one thing is we will try to see if we can address the issue of not putting everyone in methadone, which is the riskier one, because we use more today of the Suboxone treatment, which is less risk for overdose, and so the patients who can be at placed in the MAT, medication assisted treatment, we'll try to see if we avoid the use of methadone, because honestly it's the riskier one. But for many patients it is life savior, because honestly heroin is a much worse situation. So then methadone is really a bad choice in a sense, but it's a lot better for the patient. It's to save more lives than heroin. That's why.
Right, thank you. Let's move along. We still have a lot more to our meeting. Sally.
Yeah, I think 3 questions. One is, what percentage of your outpatient treatments right now are methadone? My second question is this essentially you're coming to us to ask about the introduction of a new inpatient treatment facility in our neighborhood? Will the building that is currently owned by you, Dr. Taveras, be sold to this institution and converted into an inpatient treatment facility? Is that the idea?
What happened there?
The building is his.
Say that again, I'm sorry.
Right, I understand that. Will it be sold to the institution? Will ownership of the building change to accommodate this new inpatient treatment facility?
Okay, I'm sorry. You're gonna say, the question is if I own the building since 2006. So and the question is, you said something about selling the building?
Right, will ownership change to the institution, from you to the institution? Are you selling the building to the institution, to the inpatient facility, and then converting it?
Well, in that particular case, honestly, the structure in terms of what is, when you mean the institution means like what, MIH or?
Yeah,
whatever you call the new inpatient treatment.
No, the institution will be a lease, do a lease to the ownership of the building, which is a different corporation. We'll be leasing the facility, but both, if I am I'm the owner of the company that owns the building.
Right, so, and you will retain ownership?
I will retain ownership, yes.
Okay, the second question I had was, in your current outpatient treatment, what percentage is methadone? And then I have one other question.
Yes.
At My Hope 2020, we do not dispense methadone. We treat opiates with Suboxone.
Okay. And then my last question is, I know you've addressed this before, but I still don't understand it. So if you could comment again on why there isn't a relationship with the Washington Heights Corner Project. I find that startling, to be honest.
If I may, we approached them. We actually physically approached them. They have certain practices about anonymity that they didn't want threatened. They wouldn't allow us to leave business cards. And at the end of a brief conversation with the people there, they gave us a name and said, contact this person. I personally sent an email and never got a response.
Do you think perhaps it's time to reapproach that, given that they are the Overdose Prevention Center, one of 2 in the city? I just, a non-returned email, I get non-returned emails all the time. Then I re-email and I re-email and I call and I call and I call.
Well, it's possible that, I mean, we will be interested, and this obviously that population needs to be addressed. I mean, then
I think if this facility were to open up at 179th Street, it certainly would make a lot of sense.
Yeah,
Well, the goal is that should be one of the areas for outreach because we intend to hire peers, and
Yes.
these are people that are also in recovery. Because again, we don't know when a person is ready.
Right.
You just have to continue offering them the opportunity and letting them know the resources there.
Right.
And if they're right around the corner, like I said earlier in my presentation, we cannot do treatment in silo. We have to work together as providers. So
Right.
that's the intent here.
Okay. Okay. I think that's the attitude we would appreciate. And then certainly that's a possible source of patients. And then hopefully people you can help turn around. Catherine Diaz.
Yeah. Hi, everyone. So I missed a little bit of the presentation, so I apologize if some of this is repetitive. First, I want to thank actually you guys and Steve for putting this on early in the agenda. Usually this comes to us, after OASIS approval or like pre-grant. So definitely this is the track we want, everyone to be on. I think my question is really from, so from what I gathered, right, like from my understanding, pre-pandemic, the bulk of patients at My Hope 2020 weren't necessarily folks with opiate use. I recall at one point, a good chunk of folks who use substances were alcohol or cocaine, small part were prescription pills. And if I got that wrong, that's on me. And so, I'm thinking in terms of as this conversation continues to develop, as you guys approach OASIS, for sure, something that I would want to know, and that I'm sure other folks who live in that surrounding area and wider would want to know, is maybe how that shift happened internally at the clinic, what you guys have seen that perhaps in terms of substance use coming through your doors. Additionally to that, what is the plan for, you own the building. That's usually the first step. That's harder for a lot of people, like Corner Project, for example, who took 2+ years to find the space, but you already have the space, right? But do you have that support if you were to open? And it's no surprise, I'm sure to you all, that, anytime, especially now, when it comes to shelters, when it comes to overdose centers, when it comes to anything having to do with substance use, and folks who are homeless, it is a big, how would I put it? Really contentious with folks who live in the surrounding area. And particularly on that block, with folks who already live there, who have historically, because of heroin use on that block. But just thinking about, what is that strong engagement plan to ensure that, if these services were to be granted and you open doors, that there isn't a strong engagement that's not, last minute we're here, that helps people understand these services. I think, and sorry if I'm all over the place, but part of the question too, right? Like, are you guys looking specifically at opiate detox or not, right? Because again, my understanding, and it's fine. I think that coming, and I'm just gonna give context. I worked in the community, have worked, have referred folks to your clinic, have worked also with Corner Project, and not everything is one size fits all, and that's usually what's missing here, right? Is that people think that it has to be one size fits all, that there are different thresholds and different needs in recovery, and so we need kind of tiered solutions for folks who are at different points of their journey, right? Like, I used to work with Corner Project, and a lot of folks who are Corner Project participants, and this has nothing to do with the agency itself, aren't necessarily ready for other organizations or other spaces, specifically because of the trajectory of their use, right? And where they are in their lives. So, I appreciate, and I think it'd be helpful to have a better understanding of, like, when you're thinking about who's occupying these beds, thinking of those scenarios, like, is this a clinic that is for folks who, have been through multiple detox units? Or are we thinking because of the type of space, because this is a private practice, that this might be maybe for folks who, are alcohol users that have, haven't necessarily encountered the system or had that many touch points in the system when it comes to detox facilities? I think that understanding can be helpful in terms of what the long-term projects or the long-term goals for this space can be. And just again, like, there are many needs that also, I think, also helps the community who lives in the surrounding area understand what might or will be established in the future. Just kind of some of the bigger points coming up for me.
Well, I can say that, yeah, we have, like, mentioned as a lot about the opioid crisis, because there's in fact a major crisis now, and we've been witnessing this for many years. But definitely, the population of substance abuse is largely, I mean, it's a mix of, I mean, the same population we have MIH, we have a lot of alcoholism, we have cocaine abuse, we have pills and opioids, and a mix of them. So yes, we will not necessarily focus on one particular. We want to go by, whatever happens. I mean, alcohol is definitely a very, very important, addiction in this community. So definitely, yeah. I mentioned in the beginning when I started talking that I've been seeing a huge amount of young people, having serious cases of alcoholism at the young age. Women, I mean, we haven't seen so many women abusing alcohol and having problems. So yeah, I mean, I wouldn't be able to say that this is a focus on. I said we know that the overdose crisis and the death of overdose are mostly in the area of opioid abuse. As you know, opioid had 3 different areas of effect. It goes first to the limbic system, then goes to the pain area, and then goes to the respiratory center. So it goes like this. That's why people die without noticing, because they don't realize they get the high, then they get the pain relief, and then they go boom, the respiratory center goes away. So then that's the reason why most people die from overdose, but it's not the only focus of our treatment.
Mm-hmm.
All right, that's good to know. OC.
Yeah.
You asked us about.
I'm sorry. Dr. Campos, you want to add something?
No, I just want a clarification on the first question that she asked.
Really, it was just that I was asking, is it specifically detox for opiates? That was part of my question. Yeah. Essentially, when I had referred in the past to My Hope 2020, I had realized that, a good chunk of the population that you served at the clinic when it came to substance misuse was usually alcohol, or I was surprised to know how high alcohol folks are battling at your clinic, and cocaine. And so I had asked, because I missed the first part of the presentation, if that shifted into opiates. I think it would be interesting data for the community to know, right? How those shifts have maybe increased, decreased, because I didn't realize it was a bigger part.
If I may answer it in this form, OASIS has put out recommendations. Basically, they're telling us to focus on alcohol and opiates, and in opiates to give preference to pregnant women who use opiates.
Okay.
So when OASIS says, hey, we want you to do this, we do our best to comply.
Just to add to that, Catherine, you articulate everything so well, and thank you for pointing everything you point out. So the program, just to be clear, is not specific just to opiate users. We're going to be treating also other substance use disorders other than just opiate. I guess the focus become on opiate because they are much of a high risk population, but the program is gonna be open to everyone that use any drugs and alcohol. Does that answer your question?
Yes, it does. Thank you so much.
As you understand, let me
Thank
tell you
you.
something a little bit specifically why alcohol. As you know, the inpatient treatment is mostly dedicated to, I mean, it's a large population of alcohol because it's alcohol and benzodiazepines are the riskier in terms of like detoxification, meaning like when the patient, the abstinent treatment, the treatment for abstinency is the riskier one is alcohol. I mean, people will not die from an opioid withdrawal. It will be suffering a lot, but it will not die. So then basically, so probably the most important part of the alcohol in the detoxification and rehab is alcohol and benzodiazepine. Those are the dangerous ones.
Right.
All right. All right. So what we've established is that the facility will serve a range of substance abuse issues, including alcohol and opioids.
Correct.
Okay.
Correct.
And okay, very good. And so therefore, methadone maintenance is just one, and the other drug is just one component of what you would be providing there.
Right.
Correct.
Okay, very good. OC Camera, please.
Yeah, okay, so I do have two questions. One, will you share statistics with us, not just in terms of the zip code that your patients are coming from, but more so particular blocks, not specific address, but a building number, but more like a block. I think that will help determine what's maybe missing in that block. If you have a cluster of people that are, that using drugs or things like that. So that I feel will be really important to know. My second question about the inpatient program, is it similar to Genesis 2? Do you offer a similar program like what Genesis 2 is doing?
I think Genesis 2 do detox, right?
No, they don't do detox at all. They accept new patients after 10 days of detoxification. So you have to clean for 10 days and get in the program.
Okay, so that's rehab. So our program is gonna be offering both. It's gonna be offering the stabilization and it's gonna be offering the rehab. So to your first questions in regards to the statistics, we can go back and look at the research, but for a lot of studies that get done, sometimes it's not done by a specific block. Yeah. The Department of Health comes up with a lot of the data, and sometimes it's not specific to certain area where you can narrow it down, but we can go back and take a look and see what we can find. But the program have two components, the inpatient that we're proposing. One is the stabilization, and once they get stabilized, and that will be stabilization from whatever drugs or alcohol that they use that give that physical effect of withdrawals. So they get stabilized, get passed through the withdrawal, which is medically supervised, and then they can get to the rehabilitation portion, which sounds like what you described that Genesis is doing.
Okay.
All right, very good.
Did I answer the question?
Yeah, thank you.
Okay.
All right. I think you've answered all of our questions.
Okay.
I appreciate your coming to us and spending time and letting us hear about the program. I just want to know, isn't it time for My Hope 2020 to be called My Hope 2022?
Good question.
Well,
yeah.
We're gonna have
we
to
like
say
to think that
2030,
2020 has to do more with
2030 now.
eyesight.
Is that what it is? Okay.
That you're looking at yourself
Okay.
clearly.
Oh, is that, oh, very, oh, I
what
see. Oh, okay.
you Want to take.
Okay, that's a good spin on it. Very good.
Thank you.
I thought maybe you were also celebrating the outcome of the election that year, but maybe not. That's a partisan comment, which is out of order, should not have been made. I hope we can continue this dialogue, and we're going to talk among ourselves and maybe come back to you. And I'm glad that after all these years we've made this connection, and hopefully we can learn much more about your program as time goes on. And
Thank you for
Okay.
the opportunity.
Steve, you and the rest of the board member, I wish every district have a board like this to represent their district. I am very impressed. We thank you for your time.
Okay.
And once you have the discussion, whatever you need, let us know. We're waiting to get your blessing before we can proceed forward.
Wonderful.
Somebody
I
said
don't-
earlier, it's normally the opposite, but we want to do it right. We want your blessing before we can proceed. So, you know,
That's wonderful. As Catherine said before, we certainly appreciate your coming to us early on in the process. Hawa,
yes.
how do I identify you? Do you have a title with the program? Are you?
I am Dr. Tavares' assistant.
Oh, okay. Well, that's a very important title.
Well, listen, that's why she is with me. She is great. She's, excellent. She knows what to do with this service like nobody else in New York.
Okay. Well, now I understand. Okay.
My goal is to see that, you know, and Tanya made a point, you know, we want to able to serve those in need, and that, you know, that is really people that look just like all of us.
Yeah.
You know, and those people do need voices. Our community do need to have safe places. We can't treat people that have illnesses as criminals. So in order for us to do that, it's us working together as a group.
I feel that for too long, this community has not really addressed this problem and has not recognized the fact that we in fact have a substance abuse problem that needs to be treated here in Washington Heights and Inwood. We've had arguments about this years ago, and I'm glad to see that people are now stepping forward to try to provide a much needed service. So we appreciate your being here, and we will be back in touch. And I'm certainly very pleased to be able to meet all the three of you tonight.
Let me tell you, Mr. Simon,
you so much.
you did, I mean, excellent. I mean, I'm proud of this, of my community board, seriously. I wasn't aware of so much importance.
I'm not proud of the fact that you have been in the community for, what did you say, 25 or 30 years?
Yes, I
am not proud of the fact that we have only met tonight. Something is
Exactly. You're right.
This doesn't make sense. Something is wrong with the fact that we have only now made contact. We should have been in contact for years.
Correct.
You know what? We're gonna make up by making sure we have our representation in this board.
Very good. Okay. Thank you so much.
Okay.
Thank you. Good evening.
Okay. Thank you.
Thank you.
All right.
So do we stay on or we leave now?
It's
No,
up.
we leave. I leave.
It's up to you. It's like the patients who go to your facility. They can stay as long as they want. And
Okay.
some people, I think you said, are on methadone for their entire lives. Some of them get off it quickly. So it's a comparable situation.
Yeah.
Got it.
Unfortunately, I have to leave because
It's perfectly. You're perfectly entitled to leave. You've been with us a fair amount of time. We're now going to transition to the point of our meeting where we talk about COVID-19. And
So definitely in your email to us, let us have your schedule for the board meeting. We will definitely send a representation to attend these meetings every month because we do want to be part of the community.
Okay, that's fantastic. I would love to have somebody coming on a regular basis. And I anticipate that our next meeting, I haven't discussed this yet with my committee members, but I anticipate that the next meeting will be Thursday, September the 8th, after Labor Day. We're most likely going to take a break during the summer. although I know that Tanya is very insistent that we should meet every month. But
That's Sally.
no,
Well,
I think that's you. So we're
I'm
gonna.
glad we took advantage of tonight meeting, because honestly, it would have been
Okay.
very great.
Okay. Thank you so much. Okay. So
All right, thank you.
Okay. So
Thank you, everyone.
on COVID-19,
All right,
the latest statistics show that the transmission rate in our 4 zip codes has been increasing. It's 1/3 higher than it was a month ago when we last met. It's at 202.4 cases per 100,000 people over the past 7 days. Still, somehow, we're lower than the citywide and Manhattan figures. Our positivity rates have been increasing over the last week, ending on Monday, the 30th. We're now at about 50. Positivity rates are about 50% higher than they were a month ago. In zip codes 33 and 34, both of them were 8.19%. Very unusual actually to have 2 zip codes with the same exact positivity rate. Zip code 40 was at 7.93 and zip code 32 at 7.68. 287 new cases in the week ending on the 30th, which was Monday. So 287 new cases. So that brings us now to a total since the beginning of the pandemic of over 50,000 cases in Washington Heights and Inwood, and almost 2,000 new cases since a month ago since we last met. Total deaths are now at 923, one more since May the 5th. And our vaccine rates are still about the same. Although 587 more people got their first dose and 590 more people are now fully vaccinated, but still our vaccine rates are running between 77 and 82% for 1 dose and 70 to 73% for people fully vaccinated, which, as I say at every meeting, is way below the citywide and Manhattan vaccine rates. Pauline Ferrante is still with us.
Hi, good evening, everyone. How are you?
Yeah, Pauline, thank you for staying with us.
No problem. So I guess the biggest update is, yes, the city is at high alert for COVID transmission. But the good news is that those in the 5 to 11 age range are now eligible to receive a booster. So as long as they are 5 months out from their last dose, they can now receive a booster shot. And we are seeing across the city that age group in particular, 5 to 11, are lacking in their vaccination for COVID. So we are really encouraging people to, speak to their pediatrician, to have any questions that they may have about, child vaccines for COVID-19 answered so that they feel comfortable vaccinating that particular age range. But other than that, there's really not too much new to share with the board. So I'm happy to take any questions, or if anyone has any questions for me about non-COVID related things, I'm happy to also answer those.
Okay, well, you asked for questions and you got at least 3.
Yay.
So Jay Mazer is first.
I just heard that there's a huge discrepancy between the official statistics of who has gotten COVID recently and the estimates of the infection rate. And it's been guessed that the difference is caused by the prevalence of home testing. And in the report I heard on, I believe it was WNYC today, they said it was estimated in a 2-week period, the last week of April and the first week of May, that 22% of the city's population got a dose of COVID in that 2-week period. And that isn't at all reflected in the statistics. that being the case, how do we understand what's going on?
I don't actually know for sure. So I will go back to our data team to ask sort of what that looks like. But you're right, because with home testing, it's not required to report to the health department if you test positive. I think the main takeaway is that if you do test positive, you remain home and stay isolated so you don't add to the community transmission. But in terms of having actual data and numbers that reflect the total amount of positive cases, I will confirm with our data team as to how we would be able to reconcile any discrepancies.
And that being the case, is there a certain amount of immunity that the population has, at least temporarily, from having that large a percentage of the population having gone through infection?
I mean, I think the number that people used in terms of herd immunity, actually, you know what, I take that back. I don't know for sure. I think that might have been in terms of as related to vaccine immunity. So let me get back to you on that as well in terms of, you know, whether or not what percentage of the population who's contracted COVID would equal, right? Is that your question? Sort of how people who had previous infection will be protected.
They have a temporary
temporary immunity. Yep.
Yeah.
Sure. I will definitely find out.
All right. Good questions.
You have great questions, Jay. I really appreciate them. I'm sorry that I'm not an expert in this field. I'm just a generalist, but I do appreciate all these questions and I always try my best to get you answers.
All right, very good. OC, you're up next.
Yeah, it's actually not a question. It was actually, Steve, when you were giving the statistics, I raised my hand because I want to take Coach Dave for help me out when I text him and I didn't know where to go to get my second booster. And apparently there was a bus on 207 and Broadway for about a week, I think, maybe 5 days. And when I got on the bus, it was around 4 p.m.-ish. And the bus was there since 11 in the morning and only 9 people came to get vaccinated. 9, not 19 or 99. My husband and I were like number 10 and 11, and there was another guy right after me. So I think one of the issues is that has to be publicized a lot. Like, you know, we have to bombard the neighborhood with, you know, flyers or however you want to post that there is a vaccination bus in a particular location. And maybe the bus shouldn't be in the same location for a whole 5 days. Maybe it has to move from, I don't know, Broadway to Sherman to Post to whatever, so more people can catch the bus. I'm not sure. I'm just putting it out that, I mean, I want to thank Dave for referring me to the bus, but I mean, it's really, I was like shocked that only 9 people got vaccinated in like, you know, almost the entire time they were there. That's
and I'm sorry, was this a health and hospitals bus? Do you know?
Dave, which bus was that? I would want to say yes, but I may be wrong.
Yes, it was a health and hospitals bus. They the only ones who got buses, not a van. It was the big bus.
It was actually a huge bus.
Yes, it was a big bus, a big empty bus.
Yeah.
A big bus that has never been below 181st Street.
I'm sorry, what was that?
The giant bus that never comes below 181st Street. It never comes to my part of the city.
Yeah. And what day, OC, what day did you say this was?
This was on Sunday. Hold on, I'll tell you. I'll check my card. Sunday, the 22nd.
Okay.
May 22nd.
Okay. Yeah. This is one of my big regrets, is that I never managed to get a schedule of when the health and hospitals vehicles are going to be around and where they're going to be stationed. And, I was able to get a, Dr. Thornton to station one of her vans at Broadway and Isham Street, but unfortunately I didn't make contact with her to get any updated statistics from her. I mean, I don't know if she's doing any better than the health and hospitals bus. Tanya.
Yeah, I was gonna say, yeah. Thank you, Steve, for sharing those numbers. Very enlightening. I will say the only thing I wanted to say was that expect that to get even worse with all the partying that's going to be going on this summer. Sadly, I think the gatherings, large gatherings, unmasked gatherings. I think there needs to be. I don't know where the gap is, and understand. I think people think it's over. I don't know. Maybe that could be why people are not, few people are getting vaccinated. But I do feel like, we need to keep the message out that, we have to be, conscientious about what we're doing. That is, the COVID is still there. It's still part of our lives, and that we have to be responsible in our, in what we do this summer. Because I would hate those numbers to continue to increase, but I do anticipate that they will. And there will be more problems because of what we already are starting to see, and we're not even at summer yet. So just something that, people need to be aware of. I don't know what can turn that, around, but I do think it is a problem that needs to be addressed, that people need to just understand that, everybody wants to have a good time, but there are ways to do that responsibly that won't result in this continued spread of COVID. Thank you.
I think that's a very valid point, and I think it drives me nuts when people seem to be talking about that pandemic as though it's over, when it clearly is not over. And maybe we're not seeing as many people dying and going into the ICUs as we did during the peak, but people are still getting COVID, and people are still getting sick, and some people are still dying. Maybe not in huge numbers, but it's unbelievable to me that 923 people in our community have died from COVID since the beginning of the pandemic, and still people are falling victim to this disease. Sally, you're next.
Yeah, I think the study Jay was referring to was the CUNY study that showed that the incidence of disease was 30 times that reported by the city. So that's quite a gap. I love your numbers, Steve, but I have to now multiply them by 30. My question for Pauline is, what are we doing to advertise the availability of COVID treatment drugs now, which will reduce the severity of the illness?
So I believe we do have information on our website, and we sent out information to all health providers to make sure that they are letting their patients know about treatment plans and treatment options. I think our biggest sort of messaging, though, is that treatment is not a substitute for vaccines. And so we want people to understand that getting vaccinated is the most important thing you can do. Of course, also following the core 4 guidance that we have, encouraged from the very beginning. But in terms of advertising the treatment options, I think we can do a better job. I'm not sure if we have flyers that we pass out to folks, but I believe that we had a PSA, but I can look into that just to make sure. But we are trying to make the rounds, with healthcare providers and pharmacies and sharing the information at meetings. But in terms of getting that information out to the larger public, I'll have to look into that. I think there was a public health campaign about it, but let me just double check for sure.
I'm thinking even notices in the subways and stuff like that, because a lot of times it's patient directed.
Right.
Where we hope it would come from the healthcare provider, it's really the patient pushing for the drug.
Right. No, you're right. So I will look into seeing what campaigns that we have done and if there are any plans for campaigns in the future to highlight treatment options.
Great. Thank you so much.
Thank you.
All right, that appears to be it for one more question for Pauline.
Yep.
Is there any update that on the work to be done at the District Health Center building?
No, so that information still remains the same, that it's, it's a funding priority and the timeline has not changed. So I don't have that detailed timeline, but again, it's fiscal year 23.
Right. But okay, but no further specifics on when the work may actually begin and when it's anticipated to be completed.
Not at this time.
Okay.
Well, doesn't fiscal year 23 begin next month?
July the 1st, yes.
Yes. But I don't know the specific month or date.
Yeah, but it then runs until the following June 30th.
Right.
Okay. Thank you, Pauline.
It's pinned in my notes for your board. So anytime I get an update, I will definitely announce it and share it with the board.
All right. Well, the board should probably reach out to DDC to see if we can get any information as well. I mean, not to disparage anything that you're doing, Pauline, but it might be helpful if we also reached out on our own.
Sure thing.
All right. So next on the agenda would be.
Oh, Steve.
What is that?
I just wanted to say, Pauline, you all have your work cut out for you because there's efforts to bring partying, dancing and partying into our indoors. If you've been following the news. So, we might have more partying, going on in the city, rah, good times. So good luck. That's all I'm going to say. Good luck with that.
Thank you.
Okay. All right. Next on the agenda is the report from the New York Presbyterian. Julio emailed me earlier that he had to attend another event tonight. The People's Theater Project apparently is having a fundraiser tonight. So New York Presbyterian system-wide COVID numbers, 273 patients system-wide, 35 are in the ICU in northern Manhattan at Milstein and the Allen hospitals, 71 COVID patients, 8 are in the ICU. He says here, please remember that approximately half of these patients initially came to the hospital for other conditions and upon testing discovered that they also had COVID. He also wants to highlight that there'll be a Father's Day event with Councilmember De La Rosa on Thursday, June the 9th from 11 to 2 at the Haven Plaza, and that they are working on a telehealth presentation with the Department for the Aging, which is going to go out to all the senior centers on June the 14th from 11 to 12. I also asked him what the hospital is doing to promote vaccines and to let people know that they should get their vaccines. And his response was as follows. We continue to do vaccinations at the Children's Hospital. We are setting slides aside for the June 9th Father's Day event with Councilmember De La Rosa to hopefully get people there. He told me earlier that the hotline, which was run by Northern Manhattan Improvement Corporation, has now ended. So you cannot just call that hotline anymore to get an appointment. So it's unclear to me right now how people would get appointments. He also said that he attended the last WICOA meeting, the Washington Heights Neighborhood Council on the Aging. Members mentioned that seniors are not getting boosted and not being encouraged to do so by their doctors. He says this is in line with what I hear also about pediatricians. The hospital is now looking to recruit members of the Dominican Medical Association to visit community doctors to encourage vaccinations. He spoke to their board and mentioned that the hospital will provide financial support for this effort. So hopefully we can get some more information, but I'm hoping that the hospital will do a lot more to encourage people to get vaccinated and to actually provide a place where they can get vaccinated. Is that Jay?
Yeah, I just a minor point, and I'm sure it's not Julio's fault, but I think this is the third straight month that he hasn't attended a meeting. And if he can't attend in the future, it would be helpful if he could deputize someone to represent the hospital. But my main point is this an appropriate time, since it's a hospital question, to discuss the resolution on the psych unit at Allen Pavilion?
Well, I have it further down on the agenda, but let me just say that I fell down on the job and I didn't write the resolution yet. So I'm still planning to do it. I want to bring it before the full board this month. I did reach out to Nick Artur. I don't know if he's on the call, because he's prepared to give me some information that I want to use for that resolution. But I'm gonna finish drafting it and I'll send it around so that people can comment on it. Does that answer your question?
Yeah, does that mean the resolution will be an executive committee resolution? Or how does it work? Just the structural way it works?
Well, my intention is to present it as a resolution from this committee.
Well, it's certainly the sense of the committee. We voted on it already.
Exactly, right. So we already had a vote. We didn't, as far as I'm concerned, I already know the direction that the committee wants to go in, and I'm basically updating the last resolution that we passed, except in this particular case, I am not directing the resolution at the hospital in the hope that the hospital will just go ahead and reopen the unit. I would direct the resolution to the state health commissioner and ask that the state intercede and direct the hospital to reopen the unit.
Steve, can the state do that?
I don't know why not.
All right.
But I don't think we can, as I think as Jay has pointed out last month, I don't think we can rely upon the goodwill of the hospital to expect the hospital to go ahead and do it. I think we've given them enough time. And even what really bugs the hell out of me is that we don't even get a statement from them acknowledging that they have a responsibility to reopen the unit at some point in the future. I mean, even when they tell us that the unit is now needed as a possible backup for in case of another surge of COVID-19 patients, they don't seem to admit or acknowledge that at some point after COVID, they need to bring this unit back. So that I think is particularly disturbing.
Steve, a hand up.
Yeah, go ahead.
My understanding is when the Allen Pavilion was opened, it claimed to have that it was going to serve the population with 300 beds. When I asked Julio about that several years ago, he said, to the best of his knowledge, there never was 300 beds, and he did not know that that was in fact part of the plan, even initially.
Well, this is actually a point that I've also raised, and I've raised this both in our committee meetings and at meetings I've had with the hospital officials. And so it apparently, despite the fact that the initial plan called for 300 beds, they apparently never had more than about 225 or something in that realm. But certainly it was built.
That's including the psych unit.
Yes, it is. Yes. And so apparently the rest of the space is doctors' offices. It's what was originally conceived of as a 300-bed hospital never turned out to be a 300-bed hospital.
As I pointed out several times, I think at meetings, I believe that a lot of not-for-profit hospitals are not-for-profit in name only, in that the bottom line is called a surplus instead of a profit, and they don't pay dividends, so they have more money to pay administrators and buy often unused equipment. But I think this is an example of that. And I think that the fact is that the same as a factory, the amount of floor space per dollar return is the issue. It's obvious that they could get more money returned to them from a doctor's office than a hospital bed, which they feared would be redundant. And it was done on the basis of cash return for floor space, and nothing more complicated than that.
Well, yeah, you may very well be right. I would be surprised if I don't know. I don't know the answer. I'm not an expert on hospital finance, but I would be surprised if the doctors are paying that much for their office space. I'm perfectly willing to accept the fact that there are other services besides the psych unit that probably pay much better and have higher reimbursement rates. And I'm sure they're making a lot of money off the spine hospital in particular, and the spine hospital, is also taking up now a portion of that building. But let's move on. There is no report from Columbia University Irving Medical Center. Janelle has promised to send it to us tomorrow. And Diane Ashley has stuck it out with us again. Director of Marketing and Communications for MJHS. Diane, it's your turn.
Thank you all. Isabella is experiencing sporadic positive cases of COVID among residents and staff, not a lot, but cases are popping here and there. We continue to offer weekly booster clinics to help ensure that both residents and staff are getting their boosters as soon as they become eligible for it. We educate, we encourage. If somebody new comes in, we start the process all over again. All visitors are required to show proof of a negative test within 24 hours. We are offering supervised self-administered tests for any visitor who requires a test before they go upstairs to visit their loved one. Again, in the hopes that we will keep COVID at bay. Consistent with DOH guidance, we are also testing staff weekly So we're not going by people's symptoms, if you will. We're testing staff on a weekly basis. Also wanted to extend my thanks to Mary. We were invited, MJHS was invited to present on cultural competency, diversity, and sensitivity today to the Aging Committee. And so just wanted to extend our thanks, and we'll continue to offer the opportunity to provide education to the community as often as we can. So thank you for that.
I'm sure she didn't make you keep wait for 3 hours before you could speak. Not like this committee.
Well, actually, we were the main show, so we were on for about an hour of the hour and a half between Q&A and the presentation. So
Well,
not quite the same setup, but
she did much better by you.
But we also
just glad to be here.
We
and
also
have the
limit
opportunity.
our committee meeting to an hour and a half. We don't have, extended hours for ours.
Yeah. All right. Well, this one should be closing very soon. All right. So Diane, can I just go back a little bit? You're experiencing sporadic cases of COVID among both patients and staff?
Yes.
And do the patients and the staff, I guess, can just go home and isolate themselves? But what do you have enough room to isolate the
Yes, we absolutely have a unit set up that is there ready to take any patient that, any resident, excuse me, that tests positive, and they're isolated for a period of time per DOH guidance, and then they get to return to their room after that time period is over.
And you're offering boosters to both the residents and the staff?
Absolutely.
Right.
And continuing education.
Right. Which is aimed at promoting vaccinations.
Absolutely.
Right. Okay, all visitors have to provide a proof of a negative test within 24 hours of the visit. And if they don't show up, you give them a test right there on the spot.
Correct. Just to be technically accurate, we supervise them doing a self-administered test, but yes, it's right on site so that they can test before they go upstairs.
All right. So then, they have to wait the 15 minutes to see the results on the slip.
They either find out they're pregnant or that they do or don't have COVID and they go upstairs.
Well, if they find out they're pregnant, I think you may be giving them the wrong test.
Yeah, no, just sorry, trying for a little levity at 9:30 at night.
Okay, well, it was a good attempt. Very good. Okay, thank you. Okay, we're now on to old business. I sent everybody the latest DEP service request report, and not surprisingly, actually, I was a little bit surprised because it hasn't really been that hot out, but the number one complaint for the month of May, 101 complaints, hydrants running full. And the number 3 complaint was just hydrants running. So together that was 140 complaints out of 330 that were logged by Washington Heights Inwood residents during the month of May. I don't have the street and sidewalk cleanliness ratings. The update on the water main, gas main installation project in Washington Heights is that it is now 99% completed, substantially completed as of Friday, May 27th, last Friday. The contractor is presently working on the final punch list items. I learned today that our recycling statistics are published by the sanitation department on its website, but I didn't have a chance to check the website. I will do so, and then I will send that information around to the committee members. I would, from now on, I think we will keep track of those numbers as well so that we can monitor how we're doing on recycling on a regular basis. That's the old business that I have. Mary, you have old business?
I have a question about the parking, the alternate side parking. Some time ago, there was, I received an email saying that come July, that they were going to go back to the twice a week on each side alternate parking. Is that happening or?
I don't think that applies to our district.
Okay,
Our district has once a week on each side.
yeah, but that email seemed to supersede that. Can you check that out?
But yeah, I would like to check that out. Could you forward that email to me?
If I can find it, it's a while ago. I'll try.
All right, well, see what you can do. Did
Okay.
it come from our office?
No.
Oh, okay. OC.
Yeah, it's kind of, I'm not sure if it's really old business or not. I think it is. I asked a few times to invite Con Edison to speak to us about microgrids because they're already working on the one in any way in Brooklyn. And so that will be extremely beneficial to find out exactly what it is that they're talking about in terms of the, the space that those microgrids will be stationed, what's their plan in terms of locations in our district, and so excuse me, and so forth. So
well, it's on my list, so hopefully we'll get to them in the fall.
Okay. All right. And my usual other thing is the textile recycling that probably, I'm just going to say textile recycling one more time.
Okay, well, I wish somehow magically it would reappear. I did send an email, I believe, to the woman I deal with at the Green Market. I don't think she answered me. It turns out it was her, according to Facebook, it was her birthday yesterday. I'll try to check on it again and try to get you an answer. Emily.
Hi, I'm not sure if this was addressed earlier. Sorry, I couldn't attend the meeting. There's another committee meeting at the same time that I didn't know. But some people have been asking me that had tested positive if there are still services in the city that send, and I meant to ask this when a speaker was talking about this earlier, that send food, or put them in a hotel. That ended a while back, but still have services like that for people that test positive. Is that still going on, or that was temporary?
I haven't heard of it in a while. Is Pauline still with us? No, we lost Pauline. I don't know. We'll have to.
Because once a person tests positive, they still
Right.
have to get food,
Right.
and go out into the world. So.
All right. Well, we'll see if we can find out.
Mm-hmm.
Okay. All right. Very good. Is there a new business?
Motion to adjourn.
Well, actually, not Sally. Before we go adjourn, I think we still have an opportunity to have an e-waste day, and we never really settled on where we should try to do it, what location we should try to use. I think we only got as far as saying it should be somewhere in Washington Heights. Does anybody have maybe a brilliant idea of where you think we could get the most response from people who would come out and bring out their old TVs and computers and electronic gadgets?
I guess from my perspective, without a lot of advanced marketing, which we won't have time for, given this has to take place in June, I would locate it in Inwood. not Washington Heights. We've never had success in Washington Heights, and our doing the e-waste recycling there is going to require some pretty significant advanced marketing. But just my opinion.
Which location we're talking about, Sally?
Which location?
Yeah,
In
the
Inwood
Isham Seaman?
would be Isham and Seaman, where it always is, because we get great turnout there.
What about the 10th Avenue and you know, 10th Avenue, Dykeman, Nagel, one of those?
Again, that would require advanced marketing, which I don't think we have time for. I mean, I'm up for anything, but I'm just saying, if we want to guarantee a successful e-waste recycling event, we hold it at Inwood Hill Park at Isham and Seaman. We can perhaps do a satellite facility at the Dykeman houses, because we've talked to them about that in past years.
But when do they normally do the e-waste at Isham and Seaman?
I think the last time was in the spring, not in the summer.
Well, of 2019, you mean to say?
Right.
No, didn't you do it more recently than that?
I have to look up when our last one was.
Well, I can't hear you.
I have to look up when our last one was. I don't have it in front of me.
Oh, I think it was more recently than 2019. So you don't think we would have to put a comparable effort into advertising it in Inwood as we would in Washington Heights?
No.
That's the unfortunate reality. I mean, we only have what, 2 weeks to pull it off.
Right.
And I feel like if we were gonna do it in Heights, then
maybe we have 3 weeks. No, I think the target date was to do it on Saturday, the 18th.
yeah, because Ebenezer said basically like checks can't be cut after the 25th, I think, or the 23rd.
Yeah, something like that. Yeah.
Something like that. So, yeah, I mean, if to do it in the Heights means to talk to like host partners that have, because the easy way is basically like the housing groups would bring in folks who live in those residentials, bring down their stuff. But, I don't think we have the time. So I think we have to do it on Isham and Seaman. And the sad reality is that, I mean, for environmentally, it's a good reality. But in terms of like equity work, the sad reality is that that block is where all those events always happen. And folks who go to the farmers market, go over there, are already kind of like tapped in and used to that. So,
and we do advanced marketing at Friends in Woodhill Park. We get the word out as soon as we know the date.
Yeah.
Also help.
The money, we got to spend it or we lose it. And so if that's the way, that's the way. And I think, for sure, when we come back in the fall, if we do have another opportunity to do it, then, we have to have it as like a standing item so that we can, definitely do the deep outreach we need to do.
Yeah, well, I mean, my hope here was that we would expand it and have it in Washington Heights. But I mean, the hospital apparently has done something at 100 at Haven Plaza at 168th Street. But still, I would think it could be successful in somewhere around 181st Street.
I mean, but I don't know don't they need like a whole block to do it?
No, I mean, you need you need a wide open space, I guess, where people can drop off all of the equipment and they can load up a truck. But I don't think you need an entire block.
I mean, I don't know, unless folks feel differently, unless there's another project, but ultimately I think, we do that and then do better next time. I'm like, I don't know.
Yeah. All right.
The RKO Coliseum location would be an open space.
Yeah, well, yeah, if the
if they'd let us use it.
Yeah, right. I think that is a good, that is sort of a good location. But
Steve and Catherine, I also want to talk to you about ways to spin the balance of that 10,000, but we can do that offline.
yeah, okay. All right, so I guess the upshot here is that I should ask Christine if she wants to go back to Isham and Seaman on June the 18th.
The United Palace is also an open space, no?
Yeah, yes, at 175th Street, and they've done it. They've tried doing it there in the past, but they didn't get a very good response. But we would, I think they did it in conjunction with WIDIC, the Washington Heights Inwood Development Corporation, and maybe there wasn't enough advertising done at that time. But yeah, I think you're right, Emily. I think 175th Street, that open area there should be a good location. It's right in the middle of the community, should serve both sides of the Broadway. All righty. All right.
Let's adjourn.
Yeah, but okay. Motion to adjourn at 9:48. All right. Thank you all. We'll be in touch.